Good afternoon. The seminar is about to begin. We welcome you to Webinar 8, How to Find Out What Value-Based Products Insurers Are Offering, with Suzanne Delbanco and Mark Gagne, presented by the National Association of Health Underwriters Education Foundation. We hope you enjoy the program, and we thank you for joining us today. Course materials have been made available to you to print or download. You may access these documents by clicking the Resource tab on the left side of your screen. You're encouraged to submit questions at any time throughout the broadcast by selecting the Forum tab on the left side of your screen. Simply type your email address in your question and click Submit. Ms. Delbanco and Mr. Gagne will answer questions at the end of the program, and questions not addressed within our available time may be answered by way of a post-conference email. At this time, I'm happy to introduce Janet Troutwine, NAHU Executive Vice President and CEO, and NAHU Education Foundation President.
Oh, hello, everyone. This is our 8th in a 10-part series that goes through November. Our series is entitled The New Healthcare Landscape. Our webinar today is a live webinar, and we are holding this live and as well as recording it. So all future webinars in this series are free, of course, and they're located on our website. So if you'd like to go back and review some of those that you may have missed, we would encourage you to do those and view all of them. Our webinar today is how to write RFIs to find out what value-based products insurers are offering. It's my pleasure to introduce our presenters for today's session. Suzanne Delbanco is the Executive Director of Catalyst for Payment Reform, an independent nonprofit corporation working on behalf of large healthcare purchasers to catalyze improvements to how we pay for health services and to promote better and higher value healthcare in the United States. In addition to her duties with Catalyst for Payment Reform, Suzanne serves on the coordinating committee of the Measures Application Partnership for the United States Department of Health and Human Services, the Healthcare Initiatives Improvement Institute Board, and she participates in the Healthcare Executives Leadership Network. Mark Gagne is a co-owner and Chief Innovation Officer of Borislow Insurance. Located in the greater Boston area, Borislow Insurance is highly regarded as a leading employee benefits brokerage and consulting firm, serving over 350 corporate and 2,000 individual clients and more than 100,000 members in 35 states across the country. Mark has more than 25 years of experience in the healthcare industry and is a pioneer in the use of consumer-driven health and wellness plans with the effort of lowering healthcare costs and improving health and well-being. Mark is passionate, as you will hear, about the power of consumerism, health and wellness to transform the workplace culture. He's a member of the Board of Directors for the Massachusetts Health Connector and the National Association of Health Underwriters, Chair of the Healthcare Cost and Quality Transparency Committee. He's a certified PPACA and self-funding expert by NAHU and has a unique ability to develop innovative solutions to complex challenges. And I'll go ahead now and turn it over to Mark and Suzanne.
Thank you, Janet. We appreciate the introduction. And Suzanne, great to be with you again.
Likewise.
So I thought what I'd do, as we have done in the previous 7 webinars, is kind of introduce our thought process or framing our discussion this afternoon. This is not a news flash to everyone listening in on the call, but healthcare costs are continuing to rise, and our clients are depending on us more now than ever to provide them with strategic and informed, insightful advice. As trusted advisors, we're responsible for understanding the markets that we work in, and as we all know, you've seen one market. Taking inventory of what our health plan partners are offering so that we can properly advise our clients and encouraging them, where possible, to create innovative and creative solutions to the rising cost of healthcare. Understanding health plan payment methodologies and also understanding the commitment to transparency and the tools that are associated with delivering transparency to our customers are critical factors that every one of us as a benefit advisor need to be aware of so that we can properly advise our clients about the solution that's right for them and the plan partner that would be right for them. How health plans pay for care, not only today but into the future, is absolutely going to impact our clients' healthcare budget. As many of us like to say in this business, today's claims are tomorrow's premium. So understanding how our health plan partners are reimbursing providers and ultimately how they're going to reimburse providers in the future for the services they provide are a big factor into delivering a solution that meets the needs of our clients. Understanding the market we work in or the markets we work in, and then also being able to assess the level of innovation that our health plan partners are providing will give us the ability to objectively evaluate the market and to provide insightful advice to our clients. So with that being said, I'm going to hand off the controls to Suzanne, and together we'll, like we have done before, navigate through this afternoon's presentation and hopefully make it worthwhile for your time. Suzanne?
Thank you, Mark. It's really a pleasure to be with all of you again, and thank you to the NAHU for including CPR in this webinar series. It's really a great opportunity to share what we have been working on and to hopefully provide the audience with some tools that can be useful. So what we're going to cover today is the healthcare crisis and why we need payment reform. And we'll spend most of our time, however, talking about how to find out what health insurers in your market are doing and strengthen your signal at the same time. And I know many of you are very familiar with putting in queries to the health insurers in your market, so I'm not here to tell you how to do your basic job. What I am going to share with you is some very specific questions that you may want to pose in the area of payment reform that you might not have thought of before. And then I'll share with you some other related tools and strategies that might be helpful to you. And then we will have some time for questions from the audience, and Mark will help moderate that portion of this webinar together. So let's just start by a little bit of background. It's always good before you get into the weeds to think about why it is that we care about what it is we're about to talk about. And I think all of you are very familiar with the fact that the way we pay for healthcare today is draining value out of the healthcare system. We know from more and more research that mounts every year that the system is really failing in many areas in terms of the safety of the care that's delivered and the quality of the care. And factors that have nothing to do with quality and value are also driving up costs. So the fact that hospitals and physicians are consolidating with each other and gaining more power in the marketplace and able to charge higher prices, that's one of the leading drivers of healthcare cost growth today. So at the end of the day, when we think about the value we're getting for our healthcare dollar, it's just not what it should be. It's not reliable, and it's not high value. So one of the ways we can try to rectify that situation is to coordinate what we're asking for from health insurers and from those who pay providers when it comes to payment reform. That kind of coordination, creating a critical mass, asking the same questions at the same time, can send a much stronger signal to the marketplace about what it is that we want from it. And that's really what we're going to be focusing on today. Sorry, I'm just waiting for the next slide to come up, and my system's a little slow. Here it is. Why do we need payment reform? I've talked about the poor value. The way we've been paying for care historically has been, as many of you know, fee-for-service, where we pay for each unit of care that's delivered, and we pay regardless of whether the care is of high quality or whether it was appropriate in the first place or whether it was delivered to the right patient. And what we're trying to do is, through changing the way we pay for care, bring greater attention to the need for quality improvement, to greater attention to the need to reduce waste in resources, and to make care more efficient, and ultimately lead to higher value care that's also more affordable. So where are we today? Well, there's been a flurry of activity in the last 5 years away from traditional fee-for-service to adding bells and whistles to fee-for-service that constitute a variety of payment reforms that create both positive and negative incentives for providers, all aimed at directing them toward delivering higher value care. There is also some effort to not use fee-for-service at all, although it's much smaller, whether it's bundled payments that we talked about in the past or global payment or capitation with a twist. We are seeing an evolution of the payment methods that are being used. But most of the ones available today are really built on a fee-for-service chassis, and they are providing some kind of positive incentive for providers to meet quality standards of some kind. The incentives themselves may not be particularly powerful. They're there, but they may not be that strong. And there's mixed evidence and mixed results in terms of what actually works. With all this activity that's been happening over the last 5 years, We're also seeing these new payment methods support new models of healthcare delivery, like accountable care organizations and patient-centered medical homes. And with all these new payment methods, we're also sort of, doing watchful waiting to see what the long-term impact will be on the population's health and the affordability of healthcare, and that really is something that remains to be seen. But, while healthcare cost growth has been moderated compared to last decade, costs still keep rising. And unfortunately, there are very few signs that quality is improving. So the bottom line is our work isn't done. We need to continue to reform payment until we get the results that we want. And one of the ways that we can start that process is by our interactions with the health insurers, who then have their own direct relationships with the healthcare providers. So that's really just as background to talk about the tools and strategies that we can use to try to keep moving things in the right direction. So I'm sure many of you know what a request for information is, but it is essentially a sourcing tool that helps either an employer or one of you identify which health plan might be the best partner for a given circumstance. And an RFI can include any topic. In fact, there are some RFIs out there that are incredibly full-ranging, and they cover everything from wellness programs to behavioral health care to payment reform and price transparency. And so an RFI can include any set of topics that you wish. Our RFI that we're going to be sharing with you today is specifically focused on payment reform. So it's not going to get at everything that someone might want to know about a potential health plan partner, but it focuses and drills down very specifically around their payment reform strategy. Mark, while I'm waiting for the next slide to show up on my screen, is there anything that you want to add before I keep going?
Yeah, no, I think as we look at it, CMS just recently released data when you talk about healthcare costs continue to rise. From 2008 to 2013, healthcare costs nationally rose by 4%, but now CMS data just came out shows 5.5%. And I think when you take a look at the percentage increase overall, that's quite staggering. Now our industry is $3.1 trillion of spend with an average cost of almost $9,700 per person. So I know you've heard me say this before, but health insurance is expensive because health care is expensive. And so I'm actually very excited to share the tool that CPR has developed to help us assess what are our carrier partners doing about that. So as an example, you and I have talked about in the past in Massachusetts, the alternative quality contract. Well, we still have trend in the marketplace here in Massachusetts of 7 to 9%. So I keep asking, okay, well, if we still have trend that far and exceeds CPI, is really the payment methodology that we're experimenting with, the alternative quality contract, for example, is it really having an impact on healthcare trend? And I think in some cases you could say yes, but generally speaking, we're not seeing that. So I think the tool that you're going to share with us this afternoon will help all of us get at what are different health plans doing to tackle this very daunting challenge that our clients are experiencing in the form of higher insurance costs.
Thank you, Mark. And the one thing I want to point out, which sometimes people might not think about, is the fact that a request for information is on its face something very obvious, which is that you're asking questions and you want answers because you're trying to understand what the health plan is doing. But the questions that you ask also send a signal. They signal to the provider, the health insurer, what it is that matters to you, what you're interested in, what you're concerned about. And so we think of the RFI that we've developed as a signal to the market. And in fact, every year when we update it, which we do just to reflect the state of the market and the state of concerns among CPR members and other employers and purchasers, we get a lot of downloads. We get a lot of attention, not just from health insurers, but from providers, from all kinds of people, because it's a signal about what it is that employers and purchasers are looking for in this space. And in the past, every health insurer has gotten a different and customized set of questions from each potential customer. And when they get all that, variation in the queries that are coming their way, not only is it very burdensome to them, which some of you may care more about than others, but it also means there's sort of a cacophony of signals coming their way that aren't clear. And so one of our goals in creating an RFI that's in the public domain that people can download and edit and use as they like is that we want its use to be widespread. We want them to start getting the same questions over and over and over again so that they realize that there is demand in the marketplace for these kinds of activities. So I just want to clarify that, yes, it's a tool to gather information, but it's also a signal. When you use it, it sends a signal. So the reason why we think that can be valuable is because one of the signals we send is that we want to see progress toward payment that cuts waste or is tied to performance in some way. We want to identify for the health insurers that we think that there are some immediate opportunities where they can make tracks. Maternity care, payment reform, price transparency, various provider network strategies. We think all of these are examples of areas where they can make some fast improvements. We also want to know what they've got planned in the future. We know that it takes time to create reforms. Contracts with providers might only come up for renewal every 3 years. They might be waiting for those renewal periods to renegotiate. But we want to know what their strategy is. We want to know what they've got planned in terms of innovation. And in particular, given that we have sort of a mixed bag of benefits and potential concerns with accountable care organizations where they promise to deliver, higher value, coordinated, and continuous care for patients, but they also can lead to greater market power on the part of healthcare providers, which could lead to higher prices. We want to make sure that the health insurers are providing adequate oversight of accountable care organizations, and so we can use this tool to check on that as well. So again, the topics that we put in here, we choose very carefully. We also want this tool to be used as much as possible so that these signals become clearer and stronger. The way that the health plan request for information is organized is it's in an Excel workbook, so it's something that almost every computer and laptop has. When you download it from the internet, it will be easy to open and look at, and one of the first pages you'll see is an index that looks just like this. We've set up the RFI to start with a bunch of general questions, and then we get into some specific areas, like I mentioned, where we want to see progress made. The general questions that we focus on get down to brass tacks. You saw the statistics I was showing a moment ago about how much payment reform there is in the U.S. right now. We ask each health plan the same set of questions that allowed us to build that scorecard to individually report how much payment they have that's in bundled payment, how much payment they have that is in fee-for-service plus pay-for-performance. And quantitatively, we can then assess and compare different health plans for how much payment reform they actually have implemented. And then the Describing Payment Reform Initiative tab is where, on a very descriptive basis, they repeat over and over again descriptions of their different payment reform programs that they have in place. So they can copy that tab as many times as they want, and for each program, they answer a set of questions that allows in a more sort of qualitative way for the recipient of the information to understand the kinds of programs they're working with, the scope, the markets they're in, any results they have so far, and things like that. So it's a collection tool for information about all the programs they have underway.
So Suzanne, the last comment you made about the results, so obviously one of the things we care most about as advisors is this rapid experimentation in terms of payment is certainly helpful because we want to tackle the rising cost of healthcare, but proof of concept is something that's obviously critically important. So this tool includes the ability to ask that type of question, right? What's your proof of concept relative to the payment methodologies that you're using to reimburse your providers?
Yeah, and I want to express some caution about overselling this in the sense that we're asking the health plan to self-report results. And as of now, there is no standard way that health plans assess the impact of their programs. So each health plan might do it differently, and each health plan might even do it differently across different programs they have done. So when you get self-reported results from a health plan, you have to take them in that context and recognize that the health plan might just be reporting to you the positive results and not including the negative ones. They also might be doing their best in earnest to share their results with you, but their methodology could be pretty flawed. It's very hard at this point, without some standard approaches to evaluation, to put the results in context. But nevertheless, it's obviously helpful to get the flavor of, do they have results yet, and what have they looked like, and were they good enough to want them, to continue the program? So I think it's valuable, but I don't want to oversell it.
Yeah, no, I think that's a good point. Do you think, using as an example a health plan's trend underlying medical trend and RX trend is a good proxy for evaluating the effectiveness of these different types of payment?
It's very, very tricky. And this is actually something I'm going to be discussing with my board later today, because we at CPR are trying to shift the nation's focus not just from how much payment reform there is and making sure there's lots of it, but to trying to decide what works and so that we can learn what we should spread. In evaluating payment reform, to try to really understand the impact that payment reforms have on cost is extremely complicated, because you can look very cleanly, I think, at what kind of impact there is on resource use and utilization, and maybe even some efficiency measures. You know, how many readmissions were there after the program was implemented? What about hospital-acquired infections? Have those gone down? You know, how many admissions to the hospital were there, and did that go down for ambulatory sensitive, conditions where you should be able to prevent admissions? So there's lots of questions you can ask like that, and I think you can get pretty good information and draw some conclusions. But if you look at trend, there's so many factors that go into that, including price.
Mm-hmm.
So if the plan isn't able to negotiate with a dominant provider to get prices down, the provider might be creating all kinds of efficiencies and improving quality, but the cost might still go up because they're able to charge higher prices.
Right, and when we look at trend, I mean, unit cost is typically about 50%. So that's the big bear in the room. Unit cost is 50%, utilization is about 30%, and provider mix makes up the balance. So that's why I was asking the question: Would trend be a good proxy to understand whether these different payment methodologies are actually having an impact on lowering healthcare costs?
Yeah, absolutely. And I was just kind of expressing some caution about what the unit price portion of that.
Got it.
And how that can mask, other successes. Why don't I just move ahead to the other slides, because each of these I will delve into in a little bit more detail. So in the general questions, again, we start by asking questions about really how much payment reform the health insurer has in place. So like I said, we go method by method and ask them, out of all the dollars they're paying to doctors and hospitals, what portion is flowing through this method, the next method, and the next method. We have about 12 or 13 methods we ask them about. It's the same information that we gather for our national scorecard, but again, in this case, you would find out specifically for the health plan you sent the RFI to how much progress they've made. And there are other benchmarks we ask about too. I just was referring to efficiency and safety and resource use as all factors that we care about. So as an example, one of our benchmarks is, out of all admissions in the health insurers population, what proportion of admissions are readmissions? And that's a correlate that we're looking at over time. As there are more and more payment reforms, we would expect the proportion of admissions that are readmissions to go down. And that's something we'll be looking for. And I think over time, as we evolve our metrics, we'll want more correlates like that can help us get a sense if generally, as more reforms fall into place, are we seeing the kinds of results that we want to see. A moment ago, I was describing how we gather descriptive information also about each program that the health plan has in place. And that's what the second section really does. We find out, like I said, what method of you're using, who the program targets, what type of provider, what services are included, what markets are participating, what results are there. And by the way, we aggregate these entries when gathered through the ways that we're involved in into a resource that's on our website, which we call our National Compendium on Payment Reform. And in there, if you want to sort of scroll through and get a sense of what different health insurers are doing, you can see their brief responses to these descriptive questions and get a flavor for the kinds of programs that are in place across the country. And then as we move on from the general questions, we get into some of the specific areas. As you know from previous webinars, if you've listened to them, one of the areas that CPR continues to focus on is maternity care. And we just had our, I'm trying to remember when it was, in July, we had the third quarter calls with our health plan user groups. And I'll talk about more about the user groups in a moment. but we meet every quarter with the big national plans with our members, and especially those who are customers of those plans. And we have a progress report that they need to fill out each quarter, and we look at a lot of the same questions that the RFI covers. And just recently, I realized I had my 5-year anniversary on the job. And one of the first initiatives we started pushing was maternity care payment reform, because we know that maternity care practices in this country are not following the guidelines as much as they should. And we know we're spending far more money than we should, and there's more harm than there should be because there's a lot of unnecessary intervention in birth, and including cesarean deliveries and early elective deliveries and things like that. And so we've really been trying to push the health plans to innovate in this area. And most of them have really pushed back on payment reform. They've said, oh, we've got this great education initiative, we're using a March of Dimes toolkit, we're meeting with the providers, we're trying to convince them to change their policies. And basically, I got so tired of hearing excuses for why they weren't going to do payment reform. We finally just started asking them to report to us their cesarean delivery rate. And we are at the same rate we were 5 years ago. So I finally had the ability, once they started reporting that rate to me, to say, well, guess what? It looks like your efforts are not working. And so there is still much more to be done here. Well, I think there is greater education, and we have seen the rate of early elective deliveries go down. There still hasn't been much change with full-term cesarean deliveries, and there's some fear that as early elective deliveries go down, the rate of cesarean deliveries will actually go up at full term, because women who wanted to schedule it that way earlier will request it, toward the end of their pregnancies. And so at the end of the day, obviously, I'm not here to dictate what women do, but I know what the guidelines show, and I know what's safest for mothers and babies. And so to the degree we want to try to build that into our healthcare system, we do need to use financial incentives to get us there. And so I'm trying with renewed energy 5 years in to get the health plans to really make a move here. And that's what this section queries the plan about and sends a signal about. Anything you want to add on that, Mark, while I move to the next?
That one's all you. I'm not touching that one.
It was really remarkable, though, to realize it had been 5 years and there had been zero change, despite all the...
Congratulations, by the way.
Oh, thanks. So another thing we've been pushing on for almost 5 years also is price transparency. In that area, I would say we've made a lot of progress in. Mm-hmm. We still, perhaps don't have transparency on everything we want. Not everybody has access to, price and quality information, but it's way more than it was. And so this section asks the health plan what kind of tools they offer, what do they do to enable the consumer to have the information they need in seeking care around its quality and the price. And then we also ask about their relationships with other vendors, with employers. Do they allow claims data to be used with other vendors if the employer so chooses? We ask about the accuracy of the information that the health plan posts, because even though you would think they would have great information, we have found several methodological flaws in how price information sometimes is posted. And we've just started asking an interesting question. Are they making sure that providers that they contract with have adequate price information for referral purposes? So when referring a patient, do they have the information they need to try to refer the patient to a high-value provider? And that's something we know very few health plans are supporting right now. Some of them are supporting providers within ACOs that they've contracted with, but beyond that, there's not a lot of availability of this information. And we feel like if providers as a group are going to be held financially responsible increasingly and be increasingly at risk for how much spending they have with patients, they really need to have insight into how expensive the specialists are that they're referring to, and to help them identify higher value providers to develop relationships with. So this section, I think, has evolved a lot over time, but continues to push the market to support the needs of consumers and purchasers and physicians, frankly, in having what information is essential to make good decisions.
So in the area of transparency, Suzanne, I know one of the things we all struggle with is how we can help consumers make educated, rational choices on healthcare for quality versus price for procedures when there's very little information for them to be able to access and then when the time prohibits, the ability to make the best choice. So how do we get, in your opinion, consumers to engage in these types of decisions, given the limited knowledge they have when evaluating options against the doctor's recommendations? So, what are your thoughts on that particular area?
I think it's a really tricky area. Consumers and doctors are as diverse as human beings, and there are going to be some consumers who really just want to defer to their doctor, and it doesn't matter how much information and incentives we throw their way. There are going to be others who really do want to be involved in the decision and want to have ways of sort of verifying that they're making good decisions and that their doctor is doing well on their behalf. So, I think we have to work with those who are interested and eager by providing them with the information they need and, frankly, with the incentives that they need to bother to take the time to inquire. There was a new, the Kaiser Family Foundation HRET annual survey of employee health benefits came out yesterday, I think it was, and or maybe it was Tuesday. And in it they show that while again healthcare costs trends have moderated compared to the last decade, deductibles are outstripping growth in wages, and so I think more and more consumers are feeling the pinch and feeling like they do need to look and be informed about what things are going to cost them. Obviously, we don't want to go so far that we scare people and they decide not to seek services that they need. So we need to support them in a whole variety of ways, and I think there's going to be a lot of nuanced work with benefit design and incentives for consumers over time to try to figure out how to strike the right balance. So that's very related. It's a good segue to this next section where we ask what kind of provider network strategies the health insurer can support. So as you know, there's been a lot more experimentation over the last few years with narrow networks, tiered networks, centers of excellence, reference pricing, all kinds of ways of identifying for consumers which providers supposedly meet certain criteria, whether it's just cost or both quality and cost, or in some cases just quality, and creating incentives through their benefit designs for them to select those providers. And in markets that are really tough for employers and other purchasers where there's a dominant provider and there's not a lot of competition, it can be really essential to finding good value to have some innovative provider network strategies. And so increasingly we are pushing the health plans to support these strategies and wanting to know what they're capable of doing and what they're already doing. And so that's really what this section entails. And the other piece that I think is really interesting is we've been asking the plans to report to us on their success of shifting where consumers are seeking care. So we asked them to report to us, compared to last year, has there been any shift in the proportion of patients receiving care from quote-unquote high-value providers as defined by the health plan? So that is an interesting question to ask. And then obviously there's the balance here, which is, are there enough high-value providers, given how they were designated, that there's enough access for a given population? So that's, the sort of check and balance you have to look for. But this section, I think, is very important. It's not really about payment reform, but you can see how it would be intertwined because in a Centers of Excellence example, where you might identify providers that meet a great combination of being affordable and having high quality, you might, in fact, go into some kind of arrangement as a health plan with the Centers of Excellence to pay bundled payment, and then create some incentives for consumers to want to seek care from that Center of Excellence. So, payment reform and benefit designs can go hand in hand, and these provider network strategies are an essential piece of the puzzle.
Yeah, and I think I would just add to that. I mean, we've done quite a bit of tiered network, provider network strategies up here in New England, and they've had varying degrees of success. Again, I go back to the trend as a measure of it. We're not seeing trend moderate like we thought we would. And I go back to also an economic theory, right? It's supply and demand. Any economic equation has both supply and demand. This particular element is more of a supply side approach where we'll trade off the restriction of access to drive deeper discounts or different forms of payment in order to reduce cost. And in some cases it works, but invariably then you get the loud noise from the consumer saying, well, wait a minute, my doctor, my hospital is not in this network, and therefore it doesn't really have much value to me, or I have to disrupt my relationship and find a new physician relationship if I want to take advantage of this lower cost. So, I mean, I absolutely agree that it has a place at the table for discussion. But again, I think, this to me is back to the future. Let's create limited access, and then the trade-off for there is higher volume, lower cost. And I don't necessarily think it works all the time. At least we're not seeing it up here in the New England market.
Yeah, I mean, and I think that's totally fair. None of these things are going to be home runs.
No, we keep looking for them, but they're not there.
Yeah, there's no easy solution in healthcare, and I think a great example would be, the idea of a narrow network sounds very appealing. I mean, I'm a busy person. I love the idea of someone doing homework for me and just identifying the high-value providers and saying, just go here. That appeals to me on many levels. But if I get diagnosed with something rare and I need a real specialist in it and they don't happen to be in my narrow network, I might end up getting a lot of really bad care that at the end of the day is more expensive than if I had access to the right specialist. And so, I just think it's questionable over time, especially with narrow networks, whether or not they will pan out as money savers. Tiered networks are a little different because they still allow for that flexibility. So, all of this is experimentation. I think it's critical experimentation, but, I don't think we should tell ourselves that any one of these things is a magic bullet.
I agree.
So, once you've finished asking the health plan all kinds of questions about how they're currently paying for things, what kind of transparency they support, what kind of network strategies they have, it's also important, obviously, to figure out where they're heading. Some health plans are farther along than others. It doesn't necessarily mean that the others won't get there. So understanding what payment reform initiatives they have in the works, where they'll be implemented, what they're going to be utilizing, who they're going to be affecting, all of that can be very helpful in determining whether or not a health plan is going to be a good partner going forward. And frankly, if they have programs that are in development, it can provide an opportunity for purchasers, for brokers to, have a say and give some feedback as to what they think the market would value in terms of their strategy. So I think this section can be very important. It's really descriptive in nature, but obviously in thinking about a partner, you don't want to know just what they're doing now, but you want to know what they're going to be doing going forward. We also ask questions about whether or not they are working to align with public sector initiatives, because, again, if signals are important here from the purchaser to the plan through this RFI, and consistency is important here, it's also important at the end of the day that healthcare providers don't hear a cacophony of signals, but they hear a clear and strong and loud signal telling them what it is that's important. And so if you've got big public programs through Medicare, Medicaid, setting certain signals, and the commercial sector is doing something very different, it may be at cross purposes. And not to say we should always adapt or adopt the programs that the public sector is doing, but we have to recognize that they're there, and greater consistency will lead to louder signals. So it's an important thing to inquire about.
Suzanne, one of our listeners from Minnesota actually said in a conference this Monday, Blue Cross of Minnesota was talking with all the agents in that state and indicated that they're not getting much help from the provider community in terms of controlling costs. So if we're sitting here talking about different payment methodologies for providers, but yet the largest insurer, typically Blue Cross is the largest insurer in any market, and you're hearing from the CEO of the plan saying we're not getting much help from providers to control costs, what do we do with that? I guess is probably the best question.
Yeah, these conversations are always very tricky because I see the fingers pointing in all directions.
Oh, yeah.
And so, it's really hard not to get a little bit cynical and say, if I was running a big company, I would point my finger in the other direction too, because it's really hard work to change what you're doing. It's hard to change your legacy payment systems as a payer. It's hard to figure out how to automate something like bundled payment. It's really hard to figure out how to support providers with the real-time information they need to be able to succeed under new payment models. There's a lot there that's very challenging and very difficult. I also hear providers saying, we're ready, we're willing, but the plans won't do it. The plans don't know how to support it. So I just don't think there's any one truth. I think that there are providers who are resistant, there are providers who are ahead of the plans, and vice versa. So, without knowing the specifics in that state, it's hard for me to comment, on that given situation. But I would just say that I see a lot of finger pointing, a lot of excuses on the part of everybody. It's inertia. It's really hard to change. Part of how we try to, wake them up out of that inertia is to ask a lot of questions like the ones, here in this request for information, and to work together, to really try to create a consistent signal. So,
well, it's interesting in the last bullet point you put there, pushing for alignment with the public sector. I agree with you. I think one of the best kept secrets in this entire discussion is the huge cost shift from the federal payers to the private payers. On average, and don't quote me with the exact percentage, but based on what I've seen from Medicaid, which pays a little bit lower than Medicare, roughly speaking, the federal government's reimbursing 61 cents for $1 of health care. And in turn, private insurance has to reimburse $1.39 to make up for the shortfall. So something has to give. I always kind of chuckle when I hear, well, Medicare and Medicaid are excellent negotiators. So no, they're not. They dictate. It's kind of like, this is what we're paying, Mr. and Mrs. Provider. Take it or leave it. So how do we, when you say align pushing for alignment with the public sector, that the private sector has a different way of negotiating those contracts because they have to negotiate a business deal, where the federal government just dictates this is what we're reimbursing, and you have to figure out, how to deal with your cost side on your side of the table. So how do you reconcile those two things, I guess, is what I'm getting at.
Yeah, I think there are a couple. I have two different lines of answers for you. One is that alignment can mean quality measures. You're using the same payment method. It doesn't mean that your prices are going to be the same. So I just want to be clear that just by saying to the provider, here are the 20 quality measures we're going to be measuring you on, both from the public and private sector, that creates an incredible amount of consistency that might not exist otherwise. Mm-hmm. So if they know, okay, they really care about readmissions, both the commercial market and the public market, I better focus on readmissions, that's a much clearer signal than one saying, I want you to focus on readmissions, and another says, I want you to focus on discharge instructions, or I want you to focus on infections. The greater the consistency in the quality side, the better. And then also the payment method. If a provider has to learn for both sectors how to do bundled payment, then they're going to invest the resources much more readily to do that than if it's just one or the other or a piece of one. So it's more about the method and the quality measures than it is about the price. Now, let me give my commentary on the price, because I spent a lot of time looking into this with very smart health economists to write this paper we wrote a few years ago on provider consolidation and market power and what's it doing to the market. And the interesting thing that the research has shown is that, the idea of cost shifting may be cost shifting, but it also might just be price discrimination. And for those of you who took economics in college, you might remember that term. And really what it means is that whoever is charging the price will charge the maximum price they can to any party in the market. So if the maximum price they can get away with from Medicare or Medicaid is 60 cents, but they can find willing payers for $1.39, they'll charge $1.39. They might even charge $1.79 if they can. So what they found is that in markets where there's a lot of competition for providers have to work much harder to be price competitive, and they end up with much higher margins and sometimes quite positive margins on their Medicaid and Medicare payments. In markets where there's very little competition for providers and they don't have to work very hard on price, they will kick and scream and complain about how much money they lose from their public payments. And that might be because they haven't gotten their cost structures under control and they haven't really had to work that hard to find a way to make a margin at those prices. So I think, we could debate it, and there's probably a lot of gray in between what you said and what I said, but I think it's not as simple as just cost shifting.
Yep, I would agree.
So anyway, very interesting stuff, and, enough to make your brain want to explode, but hopefully that won't.
I think we both agree on that one. Hopefully that won't happen this afternoon's call.
No, it won't. So speaking of, competition and prices, as I mentioned at the beginning of the discussion, I think a lot of employers are wary about accountable care organizations. They love the idea. That there could be greater integration, better communication, more continuity, more coordination for patients than there is in this fragmented healthcare system that we have. So they love the idea. The problem is that in many cases, accountable care organizations have encouraged a lot of integration and consolidation on the part of healthcare providers. And when there is that kind of consolidation, all the evidence suggests that prices go up. And while one of the goals of accountable care organizations is to make healthcare more affordable, even if, like I was saying before, they create greater efficiencies, fewer admissions, less ER use, length of stay goes down, all kinds of good, performance on certain metrics. If when the contract comes up in 3 years and they renegotiate and realize they're the big shop in town now that they've brought so many providers under one roof, well, who's to say that the price won't be exorbitant compared to the first time? And while we may have made gains on quality and efficiency, we may not have more affordable care. So I think there's lots of things that those providing oversight of ACOs can do to try to ensure that the promise is met and not these unintended negative consequences. But you have to start by knowing what the plan's overall strategy is with their ACO. What kind of transparency are they providing? Are they just going to share quality information at the ACO level, or will they still allow consumers or patients to drill down to individual providers? Are they accepting some kind of risk-sharing arrangement where they agree that if they overspend, they will eat some of those losses, not just the payer, not just the purchaser, not just the consumer? What kind of accountability do they have for outcomes measures as opposed to just process measures? Are the incentives that go from the plan to the top of the ACO trickling down to providers within the ACO so that the frontline clinicians know what quality standards they should be meeting, know what efficiency standards they should be meeting? And what is the health plan doing to ensure that there's adequate competition among ACOs in the market? So I know I rattled that off pretty quickly. I'm curious, Mark, has there been discussion in Massachusetts about this? What's your reaction to this list?
Yeah, no, I think generally speaking, there's still a lot of unrealized potential in ACOs. Based on Medicare ACO program recent data, I guess the big question is, what's holding back success and how much longer until we begin to realize these savings? I also think, this flies in the face of the comment you just made in the prior slide, which is more competition drives down price and increases quality. It happens in every area of our economy. And so when we see more consolidation happening amongst providers, I do see, and we're actually feeling it here in the New England market, an upward pressure on unit cost because there's less people competing for the patient, so to speak. So I guess long and short is I'm still waiting. The jury's still out on the ACO. I think it's an ambitious goal. It makes sense to me, intuitively. But I guess, I'm waiting to see, what's holding back the success and how much longer do you think we're going to have to wait to actually realize some of these savings that we've been talking about?
Yeah, good point. So in addition to all of the content of the RFI, I wanted to spend some time with the group today thinking and talking about how to use it in the context of other tools and an overall strategy. So again, I'm sure many of you on the call today have vast experience in trying to determine, what assets a health plan has that could be beneficial to customers, which one might serve their needs better, and you've had various techniques for gathering that information and for analyzing that information and helping be an advisor to your customers. This RFI, again, is very specific to payment reform. It's pretty deep in a particular topic, but again, I think it's a pretty critical topic, for where we are in the evolution of the healthcare system today and in what your customers ultimately need from you, which is, higher value options. So what I would encourage you to do is if you go to our website, and I know all these tools are available on the NAHU Education Foundation website, if you go to there or you go to our website, catalyzepaymentreform.org, you can find the RFI and download it. Like I said, it's an Excel document, very easy, very small document to download, and acquaint yourself with all the questions and use it as you see fit. You can copy certain questions and add them into a different RFI that you have. You could send it on its own as a query for a specific focus around payment reform that you might have. You can use it as you see fit. The main thing that you want to know from their responses are they already making progress on payment reform? And if not, what kind of plans do they have going forward? That's ultimately what this will help you determine. And so I can't encourage you enough to use this tool as you see fit in any way that will help you. To the degree that you keep the questions worded exactly as they are and you keep sections together as they are, for any larger national plans, they've seen these questions before. They've answered these questions for big national employers. So again, the signal will be stronger with with less modification, but it's in Excel for a reason. It's there to be edited to meet your needs.
And I think it will help us establish, a health plan baseline of what they're doing with payment reform and transparency, and probably most importantly for us as trusted advisor to understand the future direction of those health plans so that we can help advise our clients from an informed perspective about where things are going with that particular, with the providers that their employee population is accessing.
That's right. So obviously there's a whole variety of steps in a relationship with a health insurer or health plan. There's choosing who you want to work with, there's settling the terms of your relationship, and then there's managing that relationship going forward. And we've tried to create tools to help at each of those stages. So the RFI is obviously about selecting who you want to work with. In addition to that, we created a companion, which is Model Health Plan Contract Language. There's all kinds of agreements that especially big self-insured customers enter into with health insurers for, whether it's for administrative services only or specific services that they're carving out. And we created basically an addendum to a base contract that gets specifically at what the health insurer will do in the area of payment reform on behalf of the customer. And so the themes in the contract language are identical to the themes in the RFI. They're meant to be sort of mirror images of each other. And this model contract language is meant to express the employer or purchaser's expectations of the health plans on how much progress they'll make, in what way, and what kind of information they expect back, the time frame for certain things being implemented, etc. This document is in Word, and it is also on our website and something that can be downloaded and, again, inserted, edited, use a section, use the whole thing. The point, again, is to create a strong, clear signal, consistent signal. And so to the degree that it's kept intact, I think it will do that more successfully. But again, use it as you need. Most of the major national health plans have signed this contract language or some version of this contract language with big customers already. So when they see it coming again, it may look familiar, and it may be something that they've already figured out how to be responsive to. And so to that degree, again, it's kind of like the RFI where consistency is your friend and can be helpful in terms of helping create a market that's more responsive in these areas. And then given that once you get a contract signed, there are relationships to manage going forward, we have a couple of tools that we hope are helpful. One is what we call our cheat sheet. It's a one-page, what we call payment reform checkup. And it is like a Cliff Notes version of the RFI all onto one page, where we chose a few essential questions that we thought really got at the crux of all the inquiries we're making. And this can be used in a face-to-face meeting, almost as a way of setting the agenda. It could be used in quarterly check-ins with the health plans. However you interact with them, it can be a way of, in a live setting, bringing the same kinds of queries to the health plan so that they understand you're interested in payment reform, you want to see progress, you want to know what they're doing, you want to know what they're doing to support price transparency, maternity care reform, etc. So I think if the RFI is too overwhelming or there's not going to be a new sourcing process happening anytime soon, this is a document that can help you get in on the act and start getting involved in pushing for payment reform and asking questions about payment reform.
Yeah, and Suzanne, I would just add, when you talk about that last bullet point, what is your strategy to advance transparency? I think in Massachusetts we passed a law in 2012 that requires actual contracted cost transparency. The challenge with the way it was actually implemented, which became effective in October of 2014, was it put the onus on the health insurers or the health plans to be the ones who disclose that information to the consumer when they're contacted by the consumer. And then also have that consumer be told what their out-of-pocket exposure would be based on the plan they're covered by that health plan. The good news is that we have a transparency law, so we've made a step in the right direction. The bad news is a report at least recently came out that, it's not been that long, right? It's not even been a year yet. But there hasn't really been a shift in behavior yet. And I think in large part that's due to the fact that most people don't know that we even have a healthcare transparency law because it's not being promoted in the general public. So I think that question is very important. Not only what are you doing to advance transparency, in other words, as a health plan, do you embrace that? But secondarily, what are you doing to promote that out in the market so that people know they have access to this information to make an educated decision? The good news is you create a law. The other part of it has to be you have to promote it and make people aware of it so they actually know that they can behave like a consumer.
Yeah, and I think the downside of that law in Massachusetts is that Massachusetts had a terrific website that people could go to that then got taken down.
Yeah.
and so now they have to. It sort of requires that much more effort on the part of the consumer to call, to know where to call, to know what to ask. And then I think there was also a really neat survey done in Massachusetts trying to determine whether if people were to call hospitals to find out how much something was going to cost, whether they could respond appropriately, and they found that the hospitals really weren't prepared to do that. So,
no, they're not. In fact, I ask my doctor every year, we kind of chuckle about it now because I've been doing it for 8 years. Hey, Doc, how much is this service going to cost me today? And he just laughs at me and says, Mark, I don't know the answer to that. I'm like, but that's wrong.
Yeah.
I haven't changed my health plan. Why can't you tell me right now? And by the way, just quick aside here, we're actually seeing physicians who are now getting out of the business of using codes and just charging a cash price. I've got one physician group who I just talked to on the North Shore who said, you know what, I'm out of the business of accepting insurance. I'm going to take a membership fee. And based on your age and your sex, I'm going to charge you a membership fee, and you can get as much health care from me as you need in a particular year. I thought that was an interesting concept. We also have other centers of excellence like Oklahoma Surgery Center out in Oklahoma. They don't even take insurance. They just say, here's our all-in price. You want an ACL repair on your knee? It's $6,797 full stop. Right? So I think it's interesting that we're starting to see now providers saying, especially if you look at the weight bearing down, which happens on October 1st, of ICD-9 codes now going to ICD-10 codes, and going from 17,000 codes to 68,000 codes. That's insane. So it's interesting to see that providers are, they're trying to figure out, not all of them, but trying to figure out, do I really want to be in this business of having to deal with billing and collecting when it's costing me 25 cents of every dollar I take in just to go get paid for the work that I'm doing? So I think I just wanted to highlight that as as something we're starting to see a lot more, not only here in New England, but other places in the country.
Yep. So in addition to the payment reform checkup, which is just the one-pager, which, again, you can get off our website or at NAHU, the activity I mentioned earlier in this discussion that CPR has been doing nationally, where we hold quarterly meetings with major health plans, and we ask them to report to us on a progress report on specific metrics, how much payment reform they've got in place and what kind of progress they're making in different initiatives. We have found this to be an incredibly valuable dynamic where we bring together a health insurer with a group of its customers. The customers ask questions, the health insurer responds, and it becomes a two-way dialogue where there can really be problem solving and we can get the supplier and the buyer, more closely aligned and keep making advancements. Because CPR staff is very small and we can only host so many of these, we have limited ourselves now to 5, and that's based on the health plans that our membership uses. But this process could be replicated. And so we took some time to create a toolkit that outlines everything it takes to run a health plan user group. So, Mark, I'll just use you as an example. Let's say you had a bunch of customers who really wanted to push Blue Cross Blue Shield of Massachusetts. You could download this toolkit, and it would have everything in there from a template invitation letter that you could send to Blue Cross Blue Shield of Massachusetts, to a template invitation letter you could send to your customers to see who wanted to participate, to a suggested year-long calendar schedule of when the meetings would take place and what the topics would be, to our template progress report that we ask the plans to fill out on a quarterly basis. There's everything in there that you could need to run this in a sort of plug-and-play fashion. And the main thing that you need is agreement on the part of the plan, enough customers, and we think that probably means, depending on their size, anywhere from 5 to 15 customers. And you need a moderator. You need someone who's going to be the convener. That could be you, for example. And it becomes a great venue. Some of the health plans have been incredibly grateful for it because while they may have client advisory group meetings on a quarterly basis, the plan sets the agenda, and they really don't know what it is that their customers want to talk about. They might do some research on that, but they've really appreciated having a venue for a two-way dialogue on this one topic in such a rich and in-depth way. And I'm not saying everybody's going to agree to it, and I'm not saying maybe that you have enough customers who immediately will make the time available, because obviously if they don't show up, it's dead in the water.
Right.
But to the degree that any of you are interested in mimicking this process, I think it can put you in a very authoritative role, in a role that allows your customers to have much closer access to the health insurer than maybe they typically do. And it gives them a way to collaborate with their peers. There's no concern around antitrust or anything like that, because none of the questions are about price or anything that kind of gets into those waters. And we do, by the way, on these calls often have public agencies as well, so state Medicaid or state employee or retiree agencies joining in, so we have some public, some private sector purchasers. And then we have also invited our members who are benefit consulting firms. So, and I know all of them are members of NAHU. So it's been a very powerful and useful process. I think we've been going at it now for 4 years. And every year I try to do a phone call with each of the plans and say, is this still valuable? Do you want to continue? And they always say yes. So we had one drop out for a little while, but we got them back. And that was because we really didn't have enough customers of theirs. But as our membership grew, and we did, they were willing to come back, and they are working with us again. So I would encourage people to take a look at this toolkit, and CPR stands by as an advisor if you decide to do it and you want some advice on any aspect of it. We are very happy to offer that.
What I like about this is it also, as we continue to reinforce our position as a trusted advisor, this helps us position us as thought leaders, as opposed to product people, which we're not really product people at this stage of the game. And given the complexity that we're dealing with our clients, they really want us to be thought leaders and help us have more richer discussions with them about how we can actually improve the spend that they're making on healthcare. So this is a great idea.
Yeah. And one of the things we suggest as an example in here is that before you have your very first user group call with the plan, obviously you do some prep work with the plan to make sure that they're comfortable and ready and, know who's going to be attending and what your expectations are of them, but also that you do a prep call with your customers without the plan, so that you can go over what the process is going to be like, how important it is for them to attend, how important it is for them to speak up and ask questions, and keep the conversation focused on what is important to them. So there's a lot of value here in terms of the relationships that you can make stronger, and I really do see that as being potentially valuable to the NAHU members. So I think, Mark, now we're turning it over to you to share additional perspective.
Yeah, I'll share just kind of wrapping up our conversation, and then have a couple of questions and a couple of statements that came through while you and I were talking. Again, as we mentioned in the beginning of the session, we all know healthcare costs are rising, and our clients are leaning on us in a way that they have in the past, but even more so now, to give them informed advice and, most importantly, give them creative and innovative solutions to the daunting challenge. Most clients, employers, are offering health insurance or benefits in general. It's their second largest investment they make behind payroll. So it's something that and it grows faster than every other line. So it's something that business leaders are absolutely focused on. Our role as trusted advisors is to understand the market that we're in, which is not an easy thing to do, especially given how quickly things are changing and how exponentially, how complicated things are. To take an inventory of what our health plans are doing, not only in the way of product, but also in the way of reimbursement and payment methodology for the services that their provider networks are delivering to our customers. And then encouraging, and this is something I'm very passionate about, encouraging and driving health plans to be more creative and innovative. Let's not try the same things from 20 years ago and repackage them under a different label and pretend that they're different, because they're not. Let's do things that are different because we know we have to. Understanding how health plans pay for services, and then whether they really embrace transparency are critical factors for us to really understand and evaluate on behalf of our customers. And how they pay for care, that is health plans, will in large part determine what the healthcare budget is for our clients. Again, as we always like to say, today's claims are tomorrow's premium, and making a connection between those two things and say, you still need to get the care you need, but you need to be thoughtful about it. And we need to teach you or help you, inform you about how that care is getting paid for, because you're ultimately going to end up paying for it in the form of premium that you're being charged by that carrier that you're working with. And finally, the tool I think you've developed, I don't think it's overly complicated, which is what I like about it. The old KISS method, Suzanne, let's keep it simple, and you've made it very flexible. So I think it's something that our members absolutely could benefit from should they take the time to access the tool and to use it with their clients. So with that being said, it's always a pleasure working with you. I think what I'd like to do is just ask a few of the questions. I'll make a couple of statements that people have sent in while they've been listening, and then we can wrap up the session. So the first thing is, what do you think we should do for physicians with high costs and low quality to help them improve on those metrics? And the second part is, how do we address this within the context of an overall physician shortage to manage access?
Yeah, those are great questions and tough ones. So I am not, I have worked in the quality improvement space to some degree, but I am not, the foremost expert on how you get poor-performing providers to perform better. I do know that there are other organizations out there that focus on this exclusively, like the Institute for Healthcare Improvement. And one of the approaches that they take is to try to identify best practices and then to create collaboratives where there are providers who perhaps are underperforming and want to learn from each other about how to achieve those best practices. And they kind of create like a support group, and they have certain change steps that they're supposed to follow, and they take those steps and they report back to each other, and they measure results, and they keep tweaking until they get the results right. So, there are support systems out there for providers who are not performing well. But, while I think that's very important, I also think it's important for consumers to know who those providers are, so that while they're getting better, they might select to go somewhere else. And then what was the second question? It was about...
Yeah, and then so it's how do we address this within the context of an overall physician shortage? Right. I mean, one of the things we are seeing a proliferation of is urgent care facilities, where physicians don't necessarily, and I grew up in a family with providers, right? So the last thing they want to do is see somebody who they really can't help or who shouldn't be seeing them in the first place. Could have gone somewhere for the service they needed. They may have been over-clubbing the reason to go to a physician. So, but in the context of creating better quality care, how do we address this with overall physician shortage to manage access? So that was the second part of the question.
Yeah, and again, there are other people who are greater experts on this topic than I am. But what I would say is that one of the things we need to do is rebalance how we're paying primary care providers compared to specialists. Mm-hmm. Physicians in training are sensitive to the job market, and they're sensitive to their earnings prospects in comparison to their medical school debt. And so if we need more people to go into primary care, we need to pay them more, or at least pay them more relative to what specialists are getting paid. And, part of what payment reform can do is to support primary care more significantly and to rebalance the amount of payments we're making to primary care versus specialty care. And that is one of the things that CPR tracks over time with our scorecards, is what is that balance of money flow. And we did see between our first scorecard and second a slight shift with more payments going to primary care than in the past. So I think that will help. I think the other thing that many people talk about is that we need to have people practicing up to the top of their license more. and that there's a lot more we can do with other healthcare professionals who are not physicians in expanding access to primary care services in perfectly sufficient ways. And then there are also going to be alternative modes of healthcare delivery. The rise of telehealth, I think, is a great example where we're finding ways to extend primary care to get people to not go to the urgent care center or to the ER if they don't need to. And we're seeing physicians expanding their office hours and recognizing people's lifestyles now and how hard it is to fit in going to the primary care doctor between 9 and 5. So I think there will continue to be innovations, but we also really have to think about as a way to make sure we don't where it really hurts.
Yeah, and when I hear you use the word rebalance, at the end of the day, when we rebalance anything, we're taking away from some to give to others. So I don't disagree that primary care physicians need to be paid better than the specialists might have to. But at the end of the day, taking away from the specialists and giving away to the PCPs, one loses and one wins, I guess is the best way to say it. So as an example, in Massachusetts, one of the things that our Attorney General has just put across the waiver wire was, she believes that we ought to start regulating provider price disparity. And I'm not a fan of that. Price fixing has never worked anywhere. So I'm kind of curious for your thoughts on that. When you say rebalancing, in my view, unless I'm hearing you inaccurately, that means one group of providers is getting less, and then some of that's being shifted to another area of healthcare. Is that what you're saying, or no?
Yeah, I mean, it's actually multifaceted and pretty complicated because there's a lot of specialty care that happens that shouldn't happen.
I agree.
So you might keep your price the same, but put in kind of controls to make sure that utilization is appropriate.
Okay.
You might institute a benefit design change where there has to be pre-certification before someone receives a certain kind of surgery that we know is done too often.
Right.
Spinal fusion is the perfect example. A lot of those cases are not appropriate. So if there's some kind of pre-certification that requires an independent evaluation of the patient, not by the surgeon to which they were referred, there's lots of ways to control the spending without necessarily changing the prices. I think we could talk about it for a whole nother hour.
Oh, sure.
Yeah, but I don't think price fixing is the only way to go. I think there's lots of things you can do to try to gauge the appropriateness, to reward appropriateness, to create payment models that support appropriateness. One example would be a joint replacement program that was set up with bundled payments to providers. And you have to ask yourself, well, they don't get the bundled payment if they decide that this patient's not appropriate for the surgery. So what do you do? Okay, well, let's come up with a bundled payment for the evaluation piece that stands on its own. So they get a payment for every evaluation they do, no matter what happens. And that way, if they're also being gauged on other appropriateness factors and outcomes, they're more likely to be selecting appropriate patients and therefore do well on those other factors. So, there's ways to think it through to help give primary care the role that it should have, and also help make sure that our specialist services are being delivered at the most appropriate time, the most appropriate way, and not when they're not needed.
So are you in favor of price regulation, provider price regulation, or no?
I don't think there's any easy discussion about that. I don't have an opinion because I think it's too complicated without knowing the context, the specifics, and all that.
Got it. So one comment that was made, and I'm curious for your reaction to it, perhaps government reimbursements for Medicaid and Medicare should be taken as pricing signals. The private sector should be reflecting in their charges. That might become a reality if providers really controlled their expenses. So curious for your reaction to that.
Yeah, I mean, I think the public sector payment amounts have been a pricing signal for a very long time. There are definitely private insurers who set their payments off some % of Medicare, for example. There have been payment reform strategies discussed around, let's say someone gets emergency services on a vacation and is, quote, out of network, capping the amount that hospital can charge at Medicare plus 20% or something like that, right? So there's lots of discussion and lots of reality around public sector payment amounts already being a basis for commercial payments. If we ultimately get to the place where the prices we're paying are reflective of the value Will there be more accord between what the public sector is paying and the private sector is paying? Probably.
You would think, right? Intuitively, you would think that would make some sense.
Right.
So another comment that came in was charging what the market will bear. Is this model appropriate for healthcare where a free market, quote-unquote, arm's length transaction does not exist? The model is the seller is all too willing and the buyer is being coerced.
So that sounds more like a comment than a question. Am I right?
It was a comment. Yeah, it was a comment. So I'm putting it out there just because I thought it was interesting, right? Because we talked about what the market will bear. But, giving an arm's length transaction, I think that the person makes a really good point. And the arm's length transaction doesn't really exist in the way it's currently constructed. So I threw that out there just as a comment that came across. How can, one other question came in, how can we help direct healthcare consumers to making the right value-based choices? And do you think government should regulate to help steer choices, or should transparency and increased healthcare literacy with greater consumer choice be the preferred option? Or is it a combination of the two? And I can read that again if you want me to.
Yeah, I don't even know if I see those as two sides of a coin or a dichotomous choice. Mm-hmm. I think that transparency is a building block to lots of things. Yep. But we know that people don't necessarily change behavior based on information alone. And so that's where the incentive piece comes in. That's where benefit design comes in. And so I think that that's going to be important. I think where government regulation comes in is by making sure that the choices available to consumers are not dangerous or not, below standard, in the sense that, for example, how the government, Medicare relies on the Joint Commission to accredit hospitals, or Joint Commission and some other parties to accredit hospitals to make sure that minimum safety standards are met. I think there's a role for that. I think there's a role for, state licensing boards. So I think that's where that comes into play. But I think that there are many other ways to influence these decisions that consumers make besides government regulation and transparency. There's the incentive piece. There's social networking. There's all kinds of ways that providers can be more transparent with their patients.
Yep, totally agree. And then the last question we have is, and it's pretty straightforward, how do I get a one-page payment reform questionnaire? So.
I should have it memorized where it is on our website, but I think it's called the Payment Reform Checkup, and it's under sourcing tools. So I believe if someone, I'm not going to lose the connection I have to the webinar right now, but if you go to our website, and I think there's a section called, oh my gosh, I should have this memorized, something like how to get involved or something like that, then you can click on the section for health plan sourcing, and then under there would be the payment reform checkup.
Excellent.
Yeah.
Great. Those are all the questions we had from our audience today. Suzanne, as always, a pleasure conducting these webinars with you. I look forward to our next one, which is on Friday, October 23rd at 1 o'clock Eastern Time. It's on payment reform in action. So, again, always a pleasure to work with you and appreciate your time.
Thank you, Mark, and thanks to all the audience for spending time with us today.
Yes, thank you all very much. Enjoy the rest of your day.
Thank you very much, Ms. Delbanco, Mr. Gagne. We also thank each of you for participating in today's program. This concludes Webinar 8, How to Find Out What Value-Based Products Insurers Are Offering, presented by the National Association of Health Underwriters Education Foundation. Thank you again for attending. Have a great day, and you may now disconnect.